Welcome to the Everyone Loves a Quitter Tobacco Cessation conference call. My name is Jenny and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. During the question-and-answer session, if you have a question, please press star then 1 on your touch-tone phone. I will now turn the call over to Jerry Henniker. You may begin.
Thank you, and I want to welcome everyone to today's webinar. It's part of the Lake Superior Quality Innovation webinar series, and the Lake Superior Quality Innovation Network is a combination of 3 quality improvement organizations: MPRO in Michigan, Stratus Health in Minnesota, and Metastar in Wisconsin. We provide collaboration to improve healthcare for Medicare consumers and share best practices and maximize efficiencies. We have a pretty packed agenda for today. I'm going to start with, we're going to cover our welcomes and introductions. And then first we're going to hear from the American Cancer Society about Everyone Loves a Quitter. Then from Essentia Health on systems change, tobacco dependence treatment integration. And then we will follow that up. We'll hold all questions until they end, and we'll have a question and answer session at the end. You can enter any questions you may have in chat. Please use the all participants when you're using that function so that all of us can see the chat questions. And I know we have had one question already about the slides, and the slides are accessible on the Lake Superior Quinn website, and we will be getting that into chat here in just a little bit. But with that, let's get started here, and first we are going to hear from Matt Flory. Matt has worked for the Minnesota chapter of the American Cancer Society for more than 15 years. In his current position as the Minnesota State Health Systems Manager, he is responsible for increasing cancer prevention and screening through strategic collaborations. Matt is chair of the Minnesota Cancer Alliance Colon Cancer Network and a member of the Measurement and Reporting Committee for Minnesota Community Measurement and the MNsure Healthcare Industry Advisory Committee. Matt has a master's degree in public policy from the University of Minnesota and a bachelor's degree in history and anthropology from St. Olaf College in Northfield. And with that, I'll turn the floor over to you, Matt.
Can you hear me okay, Jerry?
I can hear you just fine, thank you.
Okay, just want to make sure. Next slide. Thank you, everybody, for having me here today. I'm going to talk briefly before we hear the clinic intervention, which I think is kind of the main event. Just some high-level talking points to help everybody think about getting started. First, just want to reiterate that tobacco use is still the #1 preventable cause of death and disease in the United States. The majority of tobacco users actually say they want to quit, and nearly half try to quit each year. So just, we all know that it's hard to engage people who are smokers, that not everybody says yes, but just want to remind folks that we know that the majority of current smokers really do want to quit, and maybe half of them are going to try. And that's one of the things I want to encourage people to think about today. Unfortunately, only 4 to 7% of smokers are successful in quitting each year. So even though half may try to quit, we really want to make sure that they have the support of their providers, that you guys know who's not only interested in quitting, but is willing to make a quit attempt, so we can push up that percentage of current smokers who quit smoking and get healthier. Next slide. There we go. So providers could be the key, and we see this in all the literature, whether it's from the Cancer Society, the Lung Association, the Heart Association, the CDC. Tobacco users really cite that healthcare professionals' advice to quit is really an important motivator for attempting to quit. And that brief advice from you can significantly increase the chances that they will quit successfully. Next slide. So I mentioned this before, that some smokers want to quit, more than 0.5%. Actually, the most recent data I could find from the CDC is that something like 68%, almost 7 out of 10 smokers in a 2015 survey said that they wanted to quit smoking completely, not just cut back. So we want to make sure that if you know you've got a current smoker, that you don't just encourage them to quit, but engage them in a conversation. Just classic motivational interviewing. If you're a current smoker, Do you want to quit? Have you considered quitting? Is there something that our clinic or practice could do to support you in that quit attempt? You might not approach all smokers the same way. The 3 out of 10 that don't want to quit might need a different message than the 7 out of 10 that are interested in considering it. Next slide. How do you know if they want to quit? Well, I already touched on this. The simplest way is to ask them. Next slide. Here are some examples. Again, the 5 A's. I'm not turn to the CDC and the National Cancer Institute to remind us those best practices. Many folks on the call, I'm sure, really well-versed and aware of these, but just these 5 A's are good things to position people. Ask people about their tobacco use, advise them to quit, assess readiness to quit, and assist the patient in quitting, arranging for follow-up. And there's nice common phrases that you might be able to use so that we can text, so that you have some context, not just for what you could do, but specifically, how could you encourage members of your clinic practice to advise the patient to quit? Quitting tobacco is one of the best ways you can do, one of the best things you can do for your health. I strongly encourage you to quit. Are you interested in quitting? Again, notice that there are questions along the way. It's not just talking points to try to talk a patient into something, but really identify what the patient readiness is and to actualize them, to help them assess their readiness to quit, to assist them and to support them, but most importantly, to arrange for follow-up so that we're not just talking about 4 to 7% of people being successful, but hopefully a much higher percentage. Next slide. So when talking to a tobacco user, what are some of the tried and true points of advice? First of all, it's very important to acknowledge that it's hard to quit, but to offer support and to be patient with them. It's important to talk about health benefits of quitting, but think about what the immediate impacts might be. Something that's hard and long, and the payout is much farther down the road. It's a lot less tangible than some immediate impacts. And I'm going to talk about that in a little minute. A little bit more in a minute. But also consider cost arguments, because not only are cigarettes not cheap, there are other costs, things like dry cleaning or breath mints. And those are among some of the most immediate things that somebody can see as an immediate effect of a smoking quit attempt. Even if they only quit for a little while, buying fewer packs of cigarettes, buying fewer breath mints, or spending less on dry cleaning, those could be some immediate effects that can reinforce that this is something that they can do and help them see that it's something they want to sustain. Next slide. So here are some of the immediate health benefits. Again, many of you could be very familiar with it. There are lots of infographics out there that show it. But I think these are potentially very helpful ways to reinforce to folks, current smokers, that they haven't flipped the switch they can't unflip. There are some immediate effects, even within the first 20 minutes, the first 12 hours, but especially when you look a year out, your risk of coronary heart disease is about half of that of a current smoker's. So within 1 year, a current smoker can literally reduce their coronary heart disease risk to half of smokers. Within 5 years, the risk of stroke is reduced to that of a non-smoker. Within 10 and 15 years, you start to see other significant risks in terms of cancer. So, depending on life expectancy of that smoker, you might focus on different immediate effects. Somebody that's older, you might not talk about the 15-year benefit. You might just talk about the 1 and the 5-year benefit. Somebody that's younger, you might want to go through 1, 5, 10, and 15 years. Again, don't approach all smokers the same way. Don't approach all ages of smokers that want to quit the same way. Tailor the information based on a great infographic like the one that I've shown you here. Next slide. I just want to briefly go into those 5-year and 10-year pieces because they're not all on all infographics. 5 years after quitting, the risk of cancer of the mouth, throat, esophagus, and bladder are cut in half. So we're not just talking about lung cancer here. We're talking about other cancers. Cervical cancer risk falls to that of a non-smoker within 5 years. So again, especially if somebody's interested in cancer, maybe they've got a family history of cancer, those might be additional talking points you could reinforce. 10 years after quitting, this lung cancer point is usually out there. The risk of dying from lung cancer is about half of that of a person who's still smoking. But also the risk of cancer of the larynx and pancreas also decrease. Again, you might not use all of these talking points with all patients, but just to make sure that they're there for you. If you're talking to somebody about immediate health risks or you're talking with somebody who's a younger smoker and has more life expectancy. These additional talking points might be helpful in that sort of conversation. Next slide. Advice to patients, consider the cost. So again, I touched on this before. We know that smoking causes a range of health problems, but have you thought about how it affects your wallet? Some real immediate effects. The cost of cigarettes in particular, not particularly cheap and has not been getting cheaper over the years, particularly as excise taxes have gone up, not just on cigarettes, but on other types of tobacco. We also want to make sure that people quit tobacco entirely and not just move from cigarettes to e-cigarettes or to smokeless tobacco, that they understand there are risks associated with those as well. Breath mints and cough drops, those are a regular expense that maybe someone could at least cut back on or cut entirely if they're not smoking. Cleaning expenses for their clothes, their home, their car. Long-term costs relate to healthcare expenditures, not just in terms of chronic disease, but maybe even for cold, something serious like bronchitis. Those are far less common, those respiratory diseases, in non-smokers than they are in current smokers. And they might immediately see that they have fewer missed days of work and fewer medical visits within the next year if they quit smoking now. Next slide. Help them make a plan. So one of the biggest things that the Cancer Society has done over the last couple decades, and I know the Lung Association does it, and many other organizations, is to try to help people pick a day. So that if they're going to do this, they pick a date and that they tell friends and family to get their support, but also help hold them accountable. In addition to that, as providers, you can help them with brief counseling, medication if it's appropriate, refer them to resources that can complement the care that you're giving them. So that, again, implementing those 5 A's, you're not just telling them, yes, I think you should quit smoking. You're working in partnership with them to help identify how strong their commitment is and what resources you might be able to make available to them so that their interest in quitting is supported by you as a provider and by those friends and family. Next slide. The CDC has a great website, a How to Quit page. Stratus Health can help make sure that you find this website if you haven't been there before. Lots of great information in a number of great places. Not the kind of information I would encourage you to throw at every smoker, but if you find an individual who has expressed a willingness or an interest to quit smoking, they've committed to a plan, this might be a great resource to share with them, or maybe your clinic or practice wants to pick out a couple of things that you think are particularly good. Might be a good thing, might be a good conversation starter in your clinic to walk through with some of the nurses and doctors to see what they like on this page, what's good and what's not good. Not necessarily giving a patient a link, but identifying what resources are available that you particularly like. Then it's not just, oh, here are some good resources. There's a lot of good resources, but this one in particular, our practice thinks is a good resource. Next slide. The American Cancer Society does have some resources. Particularly, we update these every November. Since November is Lung Cancer Awareness Month. October is around the corner. Lung Cancer Awareness Month is in November, and on the third Thursday of every month for about the last 40 or 50 years, we have promoted the Great American Smokeout as a day that everyone can quit. Now, these materials on the site work great for the third Thursday in November, but they can work really any time of year. So check out our website. That's at cancer.org/GASO. If you can't find it, feel free to reach out to me or to Jerry. Lots of great resources that could be used by you, could be adapted to your clinic, or could be used by employers. Next slide. We have additional resources and tools for employers that could easily be adapted for patients. This is an example of a content subscription toolkit. 2017 was the most recent I could find now, but within the next week or two, we'll roll over to the 2018 version of this. Lots of template emails and articles if you're looking for 2 paragraphs or 3 paragraphs or a full page. Again, you see a table of contents, so there's a variety of tools. This tool was developed specifically for employers to use to help their employees quit, but we could easily adapt it with the Cancer Society to help. Either you could adapt it or with help from the Cancer Society, we could tweak things. Like I said, take 300 words and help you compress it down to 100 words. Next slide. There's also just the cancer.org website, particularly if people, after having a conversation with you, are interested in more information about specific cancers. I've got lung cancer teed up, but there are pages on some of the other cancers I talked about. So again, particularly if a patient has a family history of cervical cancer and they're wondering how smoking is connected, cancer.org is a great resource for them. Here's, like I said, this is just the lung cancer page. Next slide. Another thing that you might bring up, depending on your state, but particularly good in Minnesota, the fact that radon is more common in the state. That can be another part of a motivational conversation. In Minnesota, 2 out of 5 Minnesota homes have high radon levels. That's unsafe levels of radon, and radon does, in a small percentage of the population, cause lung cancer. It's particularly helpful and important to share this kind of information with current smokers because the risk from lung cancer and radon and the risk from smoking and lung cancer actually add up. So a current smoker exposed to radon is at a higher risk than just a current smoker. So radon is an additional risk factor they can test for, an additional way that the people around the smoker or somebody diagnosed with cancer can demonstrate support by trying to find out if their house has radon, and if you find it out, construction can mitigate it very easily. I tested my house and found out that we had twice the safe level of radon. For about $1,500, I was able to hire a construction company to come in and mitigate that radon risk. And just another part of the conversation, because like I said, if you're a smoker, your risk of radon is even more important because those two risk factors do add up. They are cumulative. Next slide. So I mentioned a number of times that ACS is here to help. So in addition to helping you find these toolkits, maybe giving you advice or tweaking it in your practice, my name is Matt Flory. I'm the Minnesota Health Systems Manager, but I have colleagues in Michigan and Wisconsin. Tom Rich in Michigan, Beth Brunner in Wisconsin. If you have any questions about what ACS can do to support your efforts to help your patients quit, please feel free to reach out to Tom in Michigan, to myself in Minnesota, or to Beth Brunner in Wisconsin. Next slide. And that I think is the handoff to Jill.
Yes, thank you, Matt. Great presentation, and as I said, please feel free to enter any questions for Matt in our chat section, or you can ask them live at during our Q&A session at the end of today's webinar. Next we will go to Jill, and Jill will do her presentation. I'm going to go through Jill's bio here quick. Jill Doberstein earned her bachelor's degree in public health and master's degree in policy and advocacy, both from the University of Minnesota in Duluth. She has been working in the field of tobacco control for 15 years, first as a community organizer working towards local and state level tobacco policy for national nonprofits, and more recently managing a tobacco dependence treatment program for Essentia Health. Ms. Doberstein works in the quality department and under the umbrella of chronic disease management. She has earned both a tobacco treatment specialist certification from Mayo Clinic's Nicotine Dependence Center, as well as a national certificate in tobacco treatment practice from the Association for Addiction Professionals. With that, I will turn it over to you, Jill.
Thank you, Jerry, and thank you, Matt, for teeing this up so well. If you cannot hear me, please let me know. Otherwise, I'll just keep going. Here's a quick view of my daily scope of Lake Superior, since this is the Lake Superior Quality Innovation Network, and that is my resistance band hanging from the bar there, but this was just the other morning during my 5 a.m. workout. So I want to disclose that we did receive grant funding from ClearWay, Minnesota, a health systems change grant for integrating tobacco dependence treatment from May of 2015 through April of 2017, along with a few other health systems and tribes here in Minnesota. And then following that, we had about a 14-month grant, a dissemination grant, to do basically what I will be doing with you all today. And there's a link to our case study that an evaluation firm they worked with put together about our work. So a little bit about Essentia, just a few key pieces. We are integrated health system have about 15,000 employees, 75 clinics, and 15 hospitals. And they are across most of northern Minnesota, and then a bit of northwest Wisconsin and northeast North Dakota, and then a few in Idaho as well. In terms of a landscape, at Essentia Health, we have 40,000 identified tobacco users who are patients. Across our clinic population, our care clinic population, the tobacco use rate ranges anywhere from 12% to 31%. So if we think about the national tobacco use rate, about 16% in Minnesota, where the primary population of our clinics and patients is 14%, we're significantly higher with an average of 18.6% in terms of tobacco use. Matt teed up the guidelines and best practices really well, so I won't go into this too much than to say that in the 5 A's model, we really focus here with our physicians on 2 A's and an R. We ask them to ask our patients at every visit, every time. We ask them to advise, and that's critically important. You'll see the quote over on the right saying patients who have been advised to quit smoking by their doctors have a 66% higher rate of success. And then refer on to our specialists who have been trained and certified in tobacco treatment. About 69% of smokers want to quit completely. I know Matt talked about that as well. So that asking at every visit, every time, we might just catch them when they're in at the time that they are ready. So we need to utilize that office visit opportunity every single time, not once a year or once every 5 years, but every single time. In terms of advising, this is really important. When we first started the AAR model versus relying on our physicians to do all 5 A's, we talked about how to get the most bang for our buck out of the advise piece, knowing that our patients will have a 66% greater chance of success when they're advised by their physician. So here are a couple of tips, and I realize it's a lot of text, but I know you'll get a copy of these slides that we use. So number one, and Matt said this as well, quitting smoking is the single most important thing you can do to improve your overall health, but relating that to something, a sign or symptom or chronic condition that they already have and making it personal versus just a blatant statement. If you have diabetes or vascular disease, depression or anxiety, if you're trying to have a baby, if you're having dermatology or skin issues, if your child has asthma, etc., relating those conditions to the tobacco use is key, and why they should think about quitting. Consultations to help you quit smoking are covered by most insurance plans. Many of you probably know this now with the U.S. Preventative Services Task Force giving tobacco cessation an A rating. It is covered by most health insurance plans. I'm going to skip number 3 and go to number 4 and say research shows that medication and face-to-face counseling works best. That's what we offer here at Essentia, and so we really encourage our providers to promote that internal program that we have. Research shows when you see it 3 or more times face-to-face, you have the best chance of success, and here at Essentia we have about a 50% success rate, and I'll show you more in just a minute. Then I'll jump back to number 3 because I think this is probably the most impactful. And so I think it's something that we're working towards with our rooming staff. Instead of just, in the rooming questions, screening our patients, do you smoke and are you ready to quit? Those are the 2 questions that we've asked for years. But if you're a smoker, oftentimes you're going to have your arms and ready to say no. And a yes or no question doesn't get us very far. So what we encourage is that you say on a scale of 1 to 10 or even 1 to 5, relating it to the PC-PAM scale, how willing are you to make a quit attempt? When you ask them that question, they have to think about, where am I at today? And they have to give you more than just a short yes or no answer. And that opens up the opportunity to talk about change, or to think about change talk and positive thinking. So if they say, I'm a 5, then what we do, and I'll talk about this later, write that down on our You Can Quit card, and then leave that on the keyboard for the provider. So when the provider comes in, they can say, tell me why you're 5 and you're not a 3 or a 2. What makes you that ready? So a couple of quick tips on motivating. And then the refer. So ask, advise, and then refer. We've built within our electronic medical record a very simple and easy way to refer our patients to the on-site resources that we have. Essentia is sort of broken up into markets, our East Market, our Central, and our West Market. The Duluth hub in the East Market, Central region is really Brainerd, Minnesota, and the West Market is Fargo, North Dakota. And so the provider would choose whatever market the patient prefers and whatever clinic they prefer in that area, whatever's closest to them or their home clinic. They also have the opportunity to do a warm handoff. If the tobacco treatment specialist in the clinic is there and available, they can go and grab them to introduce them to the patient right then and there. So more on utilizing the specialist model. Here's really the meat of how we integrated tobacco dependence treatment at Essentia. We trained 30 Essentia Health staff from all 3 states and 19 community partners during 2 different Mayo Nicotine Dependence Center certification courses that we brought here to Essentia Health in 2016 and 2017. They do offer traveling trainings, so we reserved one of for both 2016 and 2017 and had 30 seats to fill. The reason why I mentioned we had 19 community partners is because the funding for that came from the Essentia Health Community Health and Wellness Program, because tobacco was identified as a priority in our community health needs assessment, which means that it had a budget attached to it. So one of the ways we talked about addressing that priority is through training more specialists. And we wanted to be able to not only offer this service at Essentia, but also to meet people where they're at in the community. So we offered seats to the federally qualified health centers in our area. We offered them to tribal clinics in our area, to health services staff at the colleges in our area, all sorts of folks, behavioral health staff from different programs and services in our community, and filled those seats with partners as well. And then an additional 16 staff here from Essentia have gone down to May to receive that certification and training as well. So we now have a total of 39 staff that have been trained just during this integration period, but we had a few before that. So we're up to 49 certified tobacco treatment specialists now here at Essentia. They range, mostly they're RNs in the clinics who have been cross-trained, and then we do have a number of respiratory therapists that mostly do patient tobacco treatment, bedside consults, and work there, and then a couple of unlicensed professionals as well. Here's a map. It's a little bit outdated. We're almost a year out from this, but you can see, the diversity in terms of geography of where those little no smoking symbols are across the map. So there's really good patient access from where we were a couple of years ago. We only had a couple of tobacco treatment specialists, and they were mostly in urban like Duluth. So more on the tobacco treatment specialist integration and utilization. We started by creating ancillary schedules for our RNs in primary care, standalone versus with their peers, so that we could refer specifically to them. We've created really robust EPIC documentation tools for them. I showed you the referral order, but we also created a visit type for tobacco counseling that, when you choose that new schedule and appointment, it automatically sends our pre-assessment survey to patients via MyHealth, which is our online tool to communicate with patients. And so that incorporates the Fagerstrom scale, if they've tried to quit in the past, for how long were they successful, what medications have they tried, et cetera. So they come in with all of that information. Of course, if they don't fill it out online, we print it at registration and have them fill it out in the waiting room. The set is really a thing of beauty. It's evolved over the last 2 years with a lot of input and feedback from our team, but lots of different documentation tools, things that blow in from other sections of the chart to reduce duplication and things like that. Their treatment plan prints as an after-visit summary for the patient, including medications, instructions, their next visit, who their support team is, etc. And then also patient tracking tools. Launched a unique toll-free number for our patients to be able to schedule when they're ready. So say they get, I mentioned the card earlier, which I'll show in a minute, that the rooming staff will place on the keyboard to cue the provider to have the conversation with the scaling question in terms of readiness. But that also has our toll-free number. So if they're not ready to quit that day, they say, what, just not today, I'm not ready. They leave with that card and it has our toll-free number, and we tell them to call us when they're ready. And we also use that as a marketing around our campus, which I'll, again, talk about in a minute. We've created patient education materials, which, again, we pulled a work group of our tobacco treatment specialists together, and they helped design that. We have monthly connect calls with our tobacco treatment specialist team and utilize Basecamp, an online project management tool to communicate. We have a message board. We can do some case study conversations there. We share all of our program materials there. I record our monthly connect call and post the recording there, so it's a nice tool to stay connected as a specialty group. And then we do some proactive outreach to our chronic disease patients, and I'll talk about that in a few minutes as well. So here's our Essentia Health team of certified tobacco treatment specialists. You know, this is really the liquid gold of our program. These folks do all the hard work. I get to, I have the honor of managing the program, but these are the folks who do all the direct patient care and get to close the success of the work that we're doing. So this is our marketing materials. These plexiglass displays are in every single primary care and specialty clinic waiting room across our health system, as well as in every single retail pharmacy at Essentia Health. And then they have those rack cards that I had mentioned where patients can take one and leave with it that has the toll-free number. Here's some marketing materials that we use. We have a Essentially magazine that goes to thousands of patients, 65,000 in the East region. Here is the example where we've put articles. In the center there's another one that goes to the Central region that had 35,000 readers. In the bottom, you'll see a screenshot from a Healthy Tips for the Holidays commercial that we did on our local NBC affiliate news station. And then on the far right, we did some targeted community newspaper advertisements, and we particularly put in the tobacco treatment specialists from that area, their pictures, because we wanted to make it very personable. These are people, that you might recognize from the clinic already. It could be, your diabetes education person. It could be the nurse who does your annual wellness visit. It could be, someone you know and recognize already. They're real people. It's not somebody on the other end of a telephone or something like that. So proof is in the pudding. Let's talk about the outcomes our program has had after I've shared a little bit about how we integrated the specialist model. In the first year, which was May of 2016 to May of 2017, we referred 3,160 patients for face-to-face counseling with a certified tobacco treatment specialist. Matt, you'll be happy to see that on this graph and the next, we see a big spike in November around Great American Smokeout because we do a lot of promotion around that, and then also, of course, around the New Year time when people are interested in making some behavior change. Then in year 2, and I'll say just in this first year, it would have taken us, the primary mode we were using before for tobacco cessation was a fax referral to our state quit lines. And to get to 3,160 referrals, it would have taken us between 4 and 5 years using that model versus using our internal resources. Then year 2, 7,128, so we're seeing consistency in terms of referrals, patient interest, and utilization. So that's, 6,300 referrals in the first 2 years. And we're currently over 7,000. We can monitor that. This is all coming from a Clarity report tied to EPIC, which is our electronic medical record. We monitor this by clinic, and one thing I'll just note about this slide is that, some of these clinics are very large practices, and some are very small rural practices, so it's not necessarily, why is this one doing so well and this one not, but you can compare similarly sized clinics to see how you compare with others. And I use this slide when talking with primary care leadership. And then we also can drill down into the individual practice and look at those providers. And this is something we encourage the clinic administrator or nurse manager in that clinic to hang on their performance board, which is a tool that we use here at Essentia Health to show kind of where we're at in our clinical quality, our Minnesota community measures, that sort of thing. And so this is a great way for them to compare against their colleagues as well as over time. So each of those bars is how many referrals by month and then by each provider. So just a great way to compare among your colleagues. We've also done a number of PDSA cycles, Plan, Do, Study, Act, for process improvement. Here's one example where we had asked for a 3-month cycle to do some chart scrubbing every morning to see how many patients were coming into the clinic that day who used tobacco, and then track with a hash mark how many left with a referral, just to keep this really top of mind. There's always some new initiative or some focus, epidemic, that sort of thing, where it becomes a priority for a while. So I like the 3-month PDSA cycles and primary care to really keep the focus on this type of effort. And then they also huddle around this flow board and talk about it each day, which is great. And then we're using reporting workbench as a tool to track those patients and do that chart scrubbing. So again, back to proof is in the pudding. Here's our outcomes so far. We have 28 months of referral data and 22 months of follow-up data. And in terms of follow-up, our individual tobacco specialists use shared decision-making with their patients to decide, I'm going to call you in a week, or I'm going to check in on you in a month, after their last visit type of thing. But we have a centralized process through our quality department here with patient outreach to follow up with every single patient 6 months post-referral. So from the date that referral order is placed, that's the index date, and then a patient list is created in Clarity again, and then we pull that each week and all those patients that come on at 6 months. And so we ask them 5 questions. Number 1, did you make a quit attempt? Have you quit smoking for 24 hours or more, quit tobacco use for 24 hours or more in the last 6 months? Number 2, have you used tobacco? Have you had a puff, even a puff in the last 30 days, the last 7 days? Number 4, if you have relapsed or you haven't made a quit attempt, would you agree to an appointment to come back in or come in and see one of our tobacco treatment specialists? That is the liquid gold of what that staff person does, the centralized process. Now, I'll talk more about that in a minute. And then lastly, how satisfied were you with the services you received here at Essentia? So you'll see overall for the patients who identified that they did indeed make a quit attempt and have not had even a puff in the last 30 days or 7 days, is 40% of all the patients that we've reached. Keep in mind, we don't reach every single patient. Make 3 attempts to reach them, but we don't reach everyone. And then you'll see over on the right, in terms of interventions, best practice treatment, again, medication and 3 face-to-face visits, that only makes up about 17% of the patients that have interventions. So just something to keep in mind. And then in the middle there, the referral ordered, almost 400 patients have, from that 6-month follow-up phone call, got referrals to come in or come back in and see their tobacco treatment specialist. So people that would have been lost in that follow-up section of the 5 A's, perhaps if we didn't have the centralized process to do this. So a deeper dive, again, our overall quit rate is of the people we've reached and that have made a quit attempt is 40%. But when we drill down into a referral order and medication alone, it's 31%. Referral order medication and 1 face-to-face visit, which is probably our highest category, is 38%. And then when we get to that referral order and 3 or more counseling visits, we're at nearly 50%. So it just goes to show when you utilize best practice treatment, it works really well. And, I would argue, and we have a research grant and I have a partner in our research institute who's a research scientist looking at, when you do this in healthcare, in a primary care clinic, does that work even better than just generally 3 counseling visits elsewhere? So again, we reach about 50% of patients 6 months post-referral with 3 attempts. We send them a MyHealth first, that communication platform, and then we follow up with 2 phone calls to try to reach them to answer those questions and check in and see how they're doing and refer them back into our program if they indeed have relapsed. And then at least 56 or 56.5% of patients with a referral order had at least 1 intervention. So even patients that received a referral order don't always come in or have any type of intervention. They might get a referral but never show up, of course, which we know we have a high no-show rate in tobacco cessation counseling. So this is Dr. Flory's slide I borrowed from some of their research, but this is a general look at counseling and pharmacotherapy options and what the quit rates look like at 1 year, just to put our quit rates into perspective. Telephone quit lines have a 13% 2 to 3 sessions post-medication, you'll see the 28% there, and then they kind of dive into different FDA-approved medications for smoking cessation. But at the bottom, you'll see that combination, pharmacotherapy and counseling, you get 26 to 37% quit rate. So I feel like we're doing really well with our program and our work here at Essentia. So over the last 2 years, I mentioned 7,000 now. We're up to, my slide's already outdated in terms of unique patient referrals. About 1,500 patients have quit tobacco so far that we can identify, and that's 6 months post-referral data. Again, almost 400 patients who had relapsed at 6 months at the 6-month follow-up call. We made an appointment for them to make another quit attempt and come back in and meet with our tobacco treatment specialist. And 83% were very or mostly satisfied with the services they received. I do have a video here, and if you download the slides, you'll be able to watch it, but it's a 2-minute video patient story from a patient who had used one of our tobacco treatment specialists to walk her journey with her on quitting smoking. She never thought she could quit. She had smoked over 2 packs a day for over 50 years. She's in her 70s and has been smoke-free for almost 2 years now. It'll be 2 years soon. So it's a really beautiful story, and we were able to capture it with a very nice video. So chronic disease and clinical quality dashboard, like many of you, we monitor optimal diabetes and optimal vascular care measures, of which tobacco is one of those composite measures. For diabetes, it's the D5, for vascular care, it's the IVD4. And what we know is one of the barriers for getting to target on both of those measures is tobacco use. So we built a report, again, using our electronic medical record and Clarity to monitor how many patients were non-compliant in those measures because of tobacco and something else, or because of tobacco only. And you'll see those numbers highlighted in yellow there. Here's an example, and I'll skip this one, but for optimal vascular care, where it drills down from our whole organization to the region, to the clinic, to the practice, and then to the provider. And you'll see Dr. Sheila Kamal there. And over to the far right where you see that first red arrow, you'll see she needs one patient to get to target in this measure, but yet she has 13 patients who are non-compliant in the IVD4 only because of tobacco. So we list all of those patients. I've blacked them out, of course, but we can see when their future PCP visit is, when they're coming in next, and do they also fall in that optimal diabetic care list. So essentially, if we can help this patient quit, it's a 2-for-1. It impacts their vascular care and their diabetes care. So we use this a lot to motivate our providers and with this work. And we also developed a PDSA cycle around these chronic disease measures. 2 years ago, we focused on optimal diabetic care. Last year, we focused on optimal vascular care. And how we did that is by creating a patient list, again, with those not at target only because of tobacco. We sent them each a letter via snail mail from their provider, signed by their provider and the clinic at the bottom, talking about tobacco's impact on their ability to manage their diabetes or vascular disease, the health risks of continuing to use tobacco with that chronic condition, and then also the fact that we have the best resource to help you quit. We offer this, face-to-face counseling program. It's very successful. We include a map of where the resources are offered and the toll-free number for easy access. Then we do phone follow-up. So each of the tobacco treatment specialists are provided a list of patients from their individual clinic, and then they call, and they use standard work script to document, and the EMR to document they made the phone attempt to the patient, they introduce themselves, they talk about the program, and try to make an appointment for that patient to come in and see them. And then we monitor the outcomes, of course, and provide the feedback to the providers on the impact those things have had. And what I can tell you in just a short snippet, because I'm already running out of time, is that we've had over 150 patients who may not have otherwise received a referral come in and see their tobacco treatment specialist in the clinic. I might just skip employee cessation so we can cover a couple more things, but ultimately I can tell you 22% of our employee population who receives care here at Essentia and uses our employee-sponsored health plan are tobacco users. That seems very high, but that's the truth. And so when we take that times the annual cost to employers, $5,816 per employee per year, we're talking about $6 million a year. So we've instituted a number of things here to try to address our employee tobacco use rate and utilize the program that we've built that's been so successful. And I can tell you 150 employees have engaged in that program so far. And we do offer cash incentives for doing that, piggybacking on the Minnesota Quick Cash Challenge, which is done through Quit Plan Minnesota, which offers a $5,000 cash prize. We offer $500 through our Essentia Health Foundation, and encourage employees to enroll in both contests. So inpatient initiatives. A lot of health systems start with inpatient. As you heard, we started with ambulatory outpatient services, but then we moved on to integrating into our hospitals. We know that it offers a unique opportunity to initiate cessation because it's a smoke-free facility. It also provides patients with a salient motivation to quit, oftentimes because they've had an accident or a surgery, and very much be impacted by their tobacco use. One of our hospitals in Fargo had been providing services to patients with a tobacco treatment specialist for 7 years, so we used that as a care delivery model, and then launched a pilot here at our largest hospital in Duluth about a year and a half ago. And we wanted to focus on the fact that we can help patients avoid withdrawal while they're here with us so they don't discharge AMA, which of course then can lead to safety. We live in Duluth, Minnesota, on Lake Superior, as many of you, and that wind and cold off the lake leads to icy streets, and we don't want patients walking out and members of our care team walking out with them so that they can use tobacco. So avoiding withdrawal is huge. I'll quickly move on. We focus on that in our patient education materials. Quit for now, avoiding withdrawal while you're here with us, or quit for good, and then we offer lots of services to help them do with nicotine replacement therapy in the hospital, bedside counseling. We deliver a 4-week supply of medication to the bedside via our Meds to Beds program through the pharmacy, so they leave with the medication. We don't write them a prescription. And then we refer them for ongoing support in the ambulatory side in their home clinic if they are interested. That just shows the benefit of doing that. Some baseline information. Here's how we created an admission protocol that goes on our admission order set. It's pre-checked, like sepsis or infection prevention. So every patient who comes in as a tobacco user, they automatically have the protocol on their chart. The protocol engages more members of the care team to be able to offer both a bedside consult and nicotine replacement therapy, and those include nursing, pharmacy, and the certified tobacco treatment specialist. There's just a list of ways that we communicated that new protocol to encourage utilization and comfort with it, and to do some vetting with our physicians and different practice groups. Since our go live about a year ago, I mentioned June 15th, 2017, we've completed almost 1,900 bedside consults with our tobacco treatment specialist, 2,000 inpatient med orders for nicotine replacement therapy to avoid withdrawal, 814 discharge med orders for a 14-week supply, or for 4 weeks of nicotine replacement therapy. Oh, thank you. Which again was brought to their bedside, which is important. And initially, we worked with the Joint Commission to make sure that this was compliant, but that our members of our care team that fall under the protocol could order both the inpatient NRT and the discharge NRT, because for the first 6 months, we did a kind of a process improvement plan where our physicians were not used to ordering counter medications upon discharge, so they were missing a lot of these patients that we had worked with during their stay, and they didn't leave with that 4-week supply. So our intent was good, but it wasn't happening. So we did some process improvement and worked with Joint Commission and our compliance folks here to make sure that we could also order that discharge medication with those members of our care team that I mentioned. We also then referred 429 patients for ongoing counseling and medication management tobacco treatment specialists in their home clinic. We tried an opt-out method, just referring every patient to that, and saw huge no-show rates and blocking time on our ambulatory folks' schedule. So we decided not to do that and really make sure that we only refer people who are truly motivated to continue that cessation attempt. And then lastly, I'll just mention that we centralized the process for scheduling that ambulatory ongoing counseling, because we found that our in the hospital just weren't doing it, or if they were doing it, they were scheduling them at 3 o'clock on a Tuesday when they had their PCP kind of 14-day required follow-up on a Thursday at 10 a.m., so it wasn't convenient for the patients. So we now centralize that process as well, so they get patients scheduled kind of in tandem with other follow-up visits. Then 10 months into that pilot, we launched a system-wide protocol based off that. So now this protocol for inpatient tobacco treatment is available for all 13 hospitals and all the patients we serve. And so far, you can see the numbers there of what we've achieved. And then I just included a screenshot of the order panel and the order set below, so you can get an idea of what that looks like. Pre-surgical initiative is coming soon. The only thing I'll mention really is that we've done quite a bit of education in terms of a medical insight. We've had a grand round speaker, an expert on the topic of tobacco use and pre-surgical outcomes, and we're thinking through a couple of things in terms of a protocol for referring patients and opt-out. Any patient who has an upcoming elective surgery who is a tobacco user, we'd like to refer you to a tobacco treatment specialist. And we just do that process and let them opt out if they don't want to, rather than, would you like to meet with a tobacco treatment specialist so you can prepare to have better outcomes for your surgery? So we're thinking through that, and then we're also considering an on-site pre-op clinic for optimization services like tobacco cessation counseling, like diabetes management, weight management, that sort of thing. And there's the link to the TV spot there, that medical insight. Then the last thing I'll just mention is that much of healthcare happens outside our four walls, and especially when it comes to tobacco. We see the biggest decreases in tobacco use rates when we increase the price of tobacco, when we have smoke-free clean indoor air laws, when we start regulating these wild e-cigarettes and Juul devices. So we really fit this into our aspirational aim of our organization to do our part to support public health policy. And again, it ties in with our community health needs assessment. We wrote specific goals to decrease the impact of tobacco on priority populations. Number 1, e-cigarettes and flavored tobacco in youth. Number 2, commercial tobacco in Native American populations, and menthol in African American populations. And you'll see there's a number of physicians and experts from Essentia Health testifying in a recent policy win in the city of Duluth, which regulated where flavored and menthol tobacco products can be sold. We also have 2 cities and a county within our service area moving forward on Tobacco 21 ordinances, which again, we send letters of support from our CEO. We have physician testimony and things like that. So just a quick reflection, lesson learned, less, not more. AAR, I believe, truly is pretty effective when you integrate tobacco treatment specialists in your model. In the beginning, physicians were saying, gosh, you're asking us to do more, refer patients, use this referral button. And it's like, no, we're asking you to do less, because you don't have to do all 5 A's. You only have to do the ask and advise and then refer them on to a specialist who can really, truly walk with them on this journey and spend the time that's needed to do that. The rooming question is important, as I mentioned. Do you smoke and are you ready to quit? Giving them that scaling question so we can really assess their readiness and have some change talk type conversation. Follow-up is critical. Centralize if necessary. I shared what we do here in terms of that follow-up piece. Inpatient versus outpatient, or both and. I encourage both. Again, lots of organizations start with inpatient. We just started with outpatient and moved inpatient from there. Focusing on the inpatient quit for now has been really successful, because when we walk in the room and we have a tag hanging from our badge that says tobacco counselor, when we frame it as, we want to keep you comfortable while we're here with us. We just want to keep you comfortable. Avoid withdrawal while you're here so you can be a better patient partner. You're not, crawling out of your skin wanting to sign out, find somebody to take you out, that sort of thing, and then hopefully transition into the quit for good. Again, much of healthcare happens outside our four walls. And then last most importantly, I believe, for a large health system, a full-time program manager or full-time cheerleader, as I refer to myself as, to keep tobacco cessation top of mind and a top priority for your organization is key. That's all I have.
Thank you so much, Jill. And could you pass the ball back to me?
I did that, yes.
We have a few minutes here for questions. I don't see any questions in chat. And can I ask the operator to remind our participants how to ask a question via the phone line?
Thank you. If you have a question, please press star then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star then 1 on your touch-tone phone.
And we'll give just a few minutes for people, or a few seconds for people to get their questions. I just wanted to say a big thank you to all of our speakers today, Matt and Jill. Wonderful job of talking about the many different ways or the many different tools and resources that are available for both patients and also employees on tobacco cessation activities. I did put a link in. We do have many resources also available on the Lake Superior Quinn under the Cardiac Health Task on that website. And I'm just going to check with our operator. Do we have any questions via the phone line?
We have no questions.
Oh, and you know what? We just got a question in chat from Katie. Thank you, Katie. For patients struggling and or recovering from substance abuse addictions, are there suggested strategies and or resources for addressing their tobacco use while still being mindful from a harm reduction approach? Great question, Katie, and that I think can be for either Jill or Matt.
I'm going to defer to the expert on that one because I think Essentia has done so much in this area. I don't mean to pass the ball, Jill. Hopefully that's okay.
It's okay, Matt. So I would say this is a gap for us. We know that among our patient population, more than diabetes or vascular disease, it's depression and anxiety where we see the highest tobacco use rates. I have attended a couple of trainings now from Dr. Jill Williams, Robert Wood Johnson, and she does an excellent training for behavioral health practitioners and chemical dependency treatment folks on why you should make tobacco a priority within these populations, not delay. And I know there's some great videos and tools also on the University of Wisconsin Center for Tobacco Research, UCTRI, website as well, where you hear from behavioral health patients and chemical dependency patients saying, you know, don't discount that I want to quit too. And in fact, it's oftentimes the tobacco use that will end up killing them, not their other diagnoses. So I'll just say that.
Thank you. And I put up the slide that's also got our Lake Superior Quinn contact information. Each state, Michigan, Minnesota, and Wisconsin, has a contact person along with information that can be found on our Lake Superior Quinn website. I also wanted to mention, and I did mention it in chat, but just wanted to acknowledge again that Randy Latcher from ClearWay, who ClearWay was who provided the funds for the Essentia Health project, and she is also on our line today. And I don't know, Randy, if you wanted to say a few words, or if you also, or if there's any maybe possible resources from ClearWay that you might want to mention.
Sure, absolutely. Thank you very much. And great presentation. I appreciate the clinic systems approach, and also want to acknowledge that as many options as we can provide for commercial tobacco users as possible will really help, hopefully, as many people as we can. And so we do offer, and so does Michigan, and so does Wisconsin's the other state we're talking about, right? Yes. All of our states have quitline services, and I will tell you, I can't speak to the other two states, but for Minnesota, we do offer a specific program for those living with mental illness and or substance use disorders, and we have some pretty straightforward questions to help identify those who are interested in telephone counseling and are uninsured and underinsured, and they will then receive a more robust program, more phone calls, and access to more nicotine replacement therapy, and most importantly, access to a specially trained group of coaches who have gone through really much more extensive training to help those who are living with mental illness or substance use disorders. Joe, I'm really glad you mentioned those videos, and I think that we can help pull those together so then you can send those out, Jerry, to the group. There are some great videos from C-Tree in Wisconsin, and then also the Smoking Cessation Leadership Center here in California. I actually live in California. Has some excellent resources as well. So I think it's a great question, and you definitely don't have to feel alone in how to help people living with substance use disorders.
Thank you, Randy.
Yeah.
Thank you for that very much. And I just want to check one more time with our operator. We are at the top of the hour. Are there any questions on the phone line?
No questions at this time.
Okay. Well, thank you. With that, we'll wrap up today's webinar. I did put in chat, actually, I did re-enter the Lake Superior Quinn Cardiac Health website. There are a number of resources there which would include information from all three states, Minnesota, Wisconsin, and Michigan. Quit lines, you can find that there. Our slides will be available on the Lake Superior Quinn event site. The YouTube recording will be available there, and any other resources will also be added to that event web page. With that, thank you to all of our speakers, and thank you for everyone who joined our webinar today.
Thank you, ladies and gentlemen. This concludes today's webinar. Thank you for participating. You may now disconnect.